But transitioning out of nursing school, did you jump right away into cardiac ICU or did you do med surge as a new grad?
Uh, Definitely, I started out ICU. Like I said, I was an aide. I worked at a SNF, skilled nursing facility, and like that made me not want med surg just because of the patient load. Even for like the nurses there, they were always stressed out, like way too much, just the med passes. But I started in the ICU. It was either ICU or ER for me. I like the intensity. And I'm a competitive person anyways, like I play college baseball, competitive CrossFitter. Uh, that, that like personality trait was just kind of, I feel like in me. I give props to the med surg nurses. I have a few friends that are in med surg and the stories that they have, like that, that takes a special person too, man.
100%, because we get floated all the time to med surge, tele floors. It's rough. It's rough. It's something I can do for sure long term. So that's why I always give a shout out to tele nurses, med surge nurses, because I can't do it. Like I know some people can't do ICU, but I could do ICU. So let me just do ICU, and it always feels so good to not get floated. Just because tele med surge, there's just too much going on, and nothing ever goes my way. Because in the ICU, I'm sure you can relate. You come in with like a schedule, and you follow that schedule because patients are intubated, sedated. They're on your time.
It's organized chaos.
Yeah, exactly. It's
Oh
organized
yeah.
chaos. But it's organized chaos where the organization part is you knowing what to do and exactly what's going to happen. So you know when you're gonna give meds. You know that blood pressure is off. You know the heart rate is elevated. You know exactly what's going on. You know their labs. And in tele and med surge, you have nothing to really look at besides how the patient physically looks.
It's also funny when you work a med surg floor and somebody tells you they have a stomach ache or a headache. Because you do ICU, you're almost like scratching yourself on the head trying to figure out what intervention can I do for this headache because you're so used to troubleshooting more intense therapies to save lives.
Yeah, right. It's like we can't just stick down an NG to suction real quick. You know,
Yeah.
we gotta do lighter measures.
Yeah. What was your biggest takeaway transitioning from nursing school to being a cardiac ICU nurse?
I don't know anything. Like like nursing school, I felt like I didn't know anything then, and then like it sets you up to pass the boards, obviously. But then like once you step foot on the floor, like you're below the starting level. Like just to get to the surface, like you have to put in so much work. Um, Luckily, my preceptors, they all did a phenomenal job at kind of guiding me.
Mm.
But just understanding like you don't know anything. That was eye opening. I mean, my partner started in the cardiac ICU at a different hospital, and just hearing the stories that she had, like, just set me up to like I had no ego. Like I'm coming in here completely green, and I don't know anything. That's the biggest thing that I took away.
Mm. Yeah, that's a good point. Yeah, you completely come in green. It takes away your ego. Because if you let your ego to get involved in this, especially in a cardiac ICU, if you don't ask the right questions quick enough, people are gonna die. So it really gives you like a swift kick in the ass. It really gives you like a check into to life because you're just like, oh shit, I'm not just focusing on me right now. And if something goes wrong, the negative thing doesn't happen to me, it happens to somebody else, and that could result in death. So definitely, you gotta put that ego aside 100%.
What's been your biggest struggle being a new grad in the ICU?
Like there's so many.
Let's list a
Like
few.
like dealing with the family. Like you don't really think about that. Like starting yeah, as a nurse, like dealing with the family, the phone calls from the family. Obviously, you got to give someone updates, but like managing that, managing how you go about your shift, and then just goes back to time management. Like what you like, things have to be done at certain times. We deal a lot with soda lull, and like you got to give that at 9 and 9. And you gotta get EKGs if you're starting them on that, and like how do you set yourself up for success during that shift essentially. So definitely family, time management, knowing what's the priority. Like my preceptor Milana, she always asked me, like, okay, so like what's the priority? Who's the priority patient at this time? Like that's what you have to continuously ask yourself, like in periods throughout the shift. Okay, what's the priority? Who needs this? When can I give this? Just it's a lot of organization, controlled chaos, like you mentioned.
I like how you mentioned the accountability of knowing when to switch your priorities, because when you're precepting somebody and you're telling them what to prioritize and they don't critically think about that, that makes you a dangerous nurse, because you have to continuously be assessing that. Just like you said, you have to hang blood in one unit, or in one room I should say, and the other room has dry drips like a levo. You got to switch your prioritization for 5 minutes and go take care of that. Then a phone call comes in, you have to just know when to pick up the phone, when to tell the family I'll call back in half an hour, and hopefully you remember you set your phone onto it. So definitely things that they don't teach you in nursing school that are your biggest struggle. So I wish we had like a revamped system of having surveys to tell nursing schools how to better prepare nursing students.
Yeah, it's tough because as a new grad, it's harder for you to do that. But later on in your career, hopefully you could learn it, because both are important. It's just some things you, just like with everything else, you can't learn everything up front. You have to learn it through going through the motions. It's just some nurses don't always pick up on like these fundamental things like priority, and it is a little frustrating sometimes, especially if you're precepting or if you're just working with that nurse that her drips always run dry or her alarms are always going off because she's doing something else. Yeah. But the family one that you mentioned is huge, because nursing school doesn't teach you about the family at all. You maybe have like a leadership class, or maybe in theory you go through like the values of communication, things like that, but that's nothing you could learn in class, in book. A book's not going to be able to tell you how to talk to a family. And it's crazy because I had a patient in my last shift that came into the hospital, AFib, RVR, shortness of breath, and then when we extubated him, I was talking to him, asking him why he thinks he came to the hospital and all that, and he wasn't sure. And then I asked him if he does drugs, and he told me he doesn't do drugs. But then I told him that his drug screen came back positive for these X amount of drugs, and we talked about it for a little bit, and I asked him if his family knew. He said the family doesn't know, and he doesn't want the family knowing. So, like, how are you going to teach somebody that in nursing school, where you have to speak to the family, but the patient's wishes were for you to not mention his drug use, and he doesn't want them knowing. So it's a crazy concept like that, where you know what got him to his hospital, and the family's asking why he came to the hospital, and you know why, but you can't tell them. So that's like a crazy concept that you're going to learn as a nurse. You can't learn that in nursing school, because technically you're almost lying in a sense. But then if you do tell the truth to the family, then you're going against the patient's wishes. So it's like a crazy ethical dilemma in a sense. Like that thing you're never going to learn in a book. It's something that you have to just go through the motions and just deal with it as it arises. And it's scary.
So it's fair to say.
I totally agree. That like there was a point in my orientation where I just didn't know, like a family member would call in, give me and they wanted updates. And I literally just asked my preceptor. I was like, what do I say? Like, and I still use it to this day. Like my Milana, she basically said, like, tell them what is currently happening, like what we're doing to help, and that we are taking care of them as best as we can right now. And like that, like just framework just sets you up to be able to communicate the facts and keep you from saying too much or too little. And because like sometimes it could come back and bite you in the butt when the family does come in. So just like having like a framework or like something to refer back to for communication, because these families are like, these are super sick people, and like communication is like the golden ticket.
If you want to watch or listen to our latest episode,
You can check us out on Apple, Spotify, or watch us on YouTube.